Hi everyone, and thanks for having me. I am quite passionate about leptin, and when I said to Rod I'd do a talk about it, he wanted a title, and it was quite tricky to decide what to narrow it down to. Leptin's a really broad topic, and I kind of have chosen weight loss resistance because it seems to be quite a common theme among people that I guess come to this community or come to me, and specifically we look at leptin. But this isn't just for people that are trying to lose weight. I feel like looking at the principles of leptin and opening up this new can of worms, I guess, is important for optimal health for everybody. So I hope everyone can take something home from this. I've purposely kept it quite simple. I want it to be a practical talk where people can have some take-home points and hopefully leave with some tips on some things that they can go home and try. So just a bit of an overview of what I'll talk about. I'm going to give you a bit of my background and what actually got me to working on leptin. I'll tell you what leptin actually is, what does leptin resistance look like, what are the common causes of leptin resistance. We'll talk a little bit about some practical tips that we can go through to actually help reverse leptin resistance, and I'll tell you a little bit about testing and maybe run through a couple of cases so you can see in clinical practice how I'm treating it on a daily basis. So I'm Ravi. I graduated from the UK, from Imperial College London in 2008. I was born and brought up in the UK. I moved here in 2009 for a year to do my second intern year, and I'm still here 15 years later. So initially I worked in the hospital system. I did a bit of surgery and you know, was finding my feet, and then started to do GP training in 2013. From then on I went to have 3 children in very quick succession, and then went on my own health journey after that. Now I've put their picture here for not just because I think they're super cute, but this picture was taken in 2020. Need I say more? It was a tricky year, and at this point I had so my last baby, I developed gestational diabetes, and my obstetrician told me just because of my ethnic heritage it was inevitable. Neelam's looking at me nodding, and every pregnancy you're going to get it, and the last one I did, I was never overweight. I was pretty much exactly the same weight as I am now before I fell pregnant, and at 26 weeks after my glucose tolerance test, I changed my diet. I went low carb, nowhere near as low carb as I've gone since after that. When I look back, I was like, I'm surprised that worked. But it was lower carb than where I was at. And I learned a lot. I actually lost a couple of kilos in pregnancy, and maintained that weight till the end and had a very healthy birth, and he was great. And then obviously with 3 small children under the age of 3 years and 2 months, by the way, it was mad, life got busy. And you go back to your old habits, and I started getting a bit of, post-baby weight. So I thought, let me go back to that low-carb diet that I tried, and went down the rabbit hole, found low-carb down under, Jason Fung, the whole shebang, and actually then really did a low-carb diet and felt amazing. IBS that I'd probably had my whole life was gone, weight flew off, felt energetic, all the things that we talk about, felt really, really good. And then continued, did a couch to 5K, started CrossFit, as you do, with 3 children, and then slowly started to say, well, actually, that the IBS is coming back a little bit, and I'm not feeling as good as I was at the beginning. What's going on? This isn't, no, I'm not changed anything. I'm still pretty low carb. So then, of course, I went to carnivore, and all of a sudden, once again, felt really good. IBS went away. My psoriasis cleared up. So, found other benefits. And then, 2020 hit, and I went from, working as a part-time GP to going full-time in a respiratory clinic. It was super busy. Like I said, 3 small children, and I just tanked. My energy tanked, my health went downhill, and I wasn't feeling good. So I did a bit of deep digging into what might be going on. I hadn't, once again, still similar diet. Everything was pretty much unchanged. And I found myself learning about functional medicine. So I went down that rabbit hole and spent, thousands of dollars on doing Chris Kres's ADAPT training, and then ended up on 1 million supplements and really expensive, urine and stool and all this testing, and found that, that's the way to do it. And then, my husband said, he goes, we're going natural and your cupboard's full of supplements. And I was like, actually, this doesn't feel right. I'm patching up all these holes on the outside, and look, being the doctor, you're doctoring yourself. So you're trying to find the answers in the most natural way possible, but it didn't feel very natural. It didn't feel right, and I didn't get the answers. I stumbled upon the work of Dr. Jack Kruse and leptin. A few nodding heads there. And that was quite eye-opening, actually. And I started looking a bit more into leptin. Obviously start by measuring your own leptin, and you're like, what? And that's where, I guess, the leptin story began. I'm now moved right back to more of a lifestyle-based approach. That is pretty much the foundation of how I practice. I'm doing a master's in integrative medicine. It's the first master's being run in Australia, so it's pretty good to work with other practitioners that have similar ethoses. And I've just opened a clinic called Foundations Clinic, and I've got lovely Leah, where is she, working with me, and we're hoping to do more coaching and coach patients through some of the stuff that we're going to talk about today. So what is leptin? In its simplest form, leptin is it's a peptide hormone. It's a messenger of our energy metabolism within the body. It communicates with the brain, and it gives us a feedback on what kind of energy stores we have in the body. Its job is for satiety. When leptin comes up, we're meant to feel full. So you've eaten a meal, leptin will rise, we feel nice and full. That's in its simplest form, that's what it's supposed to do. But as the diagram suggests here, leptin can have a role in your immune system, in your reproductive system, your hormonal system. I mean, the hypothalamus is your master of your endocrine system, and that can have knock-on downstream effects. There are a few other things that leptin can do. So number one, it has a circadian rhythm, so it will rise at night, usually to about 4 hours after our last meal, after sunset, and usually synchronizes with melatonin. It can promote T3 production overnight, which increases your metabolic rate and encourages fat burning, and that usually happens in the first few stages of the night. It can actually promote prolactin production and growth hormone, which helps with autophagy in the later phases of the night, and it has a pretty key role in inflammation. And looking at all of this, it's a pretty important molecule, and it can be the master of many downstream effects. So what's leptin resistance? It's pretty much that loss of that communication. For some reason, the leptin is coming up, but our brain can't hear it. This list I've put on here is by no means exhaustive of everything that the literature has shown that can cause or contribute to leptin resistance. But I just picked some of the key things that I kind of see and I found interesting. If we have a late meal or a very high insulin spiking meal before bed, it can actually inhibit leptin's ability to communicate with the brain when we go to bed. So remember that circadian aspect to it. So that can actually inhibit our ability to listen to leptin. So we can find that happens. That's something that I see. There's actually some research indicating and showing that insulin resistance is preceded by leptin resistance. So a leptin disruption first happens, and then you then end up with insulin resistance. So that insulin spike at night is outside of insulin resistance. It's way before that. It can happen much, much earlier. Disruption of your circadian rhythm. This is a huge one, and this is one of the biggest focuses that I have in clinical practice, is working on your circadian biology. If we don't have an intact circadian rhythm, leptin cannot communicate with the brain. It is a circadian hormone, like many, many, many things in our body. We are on a circadian clock. And I reinforce that. My patients can attest to it again and again. Inflammation. So that can be adiposity. We know obesity is a disease of inflammation of the adipocytes. It can be inflammation at the site of the leptin receptors in the brain. So inflammation is a broad term, but at a cellular level, I look at the mitochondria, and I use that as a bit of an analogy to explain to patients what is inflammation and what is contributing to leptin resistance, and that's a big focus also on the recommendations that I make, and then stress. My case was one of them. I see it again and again. Lots and lots of stress, spiking lots of cortisol. Is that a circadian thing? Is it what? But I do see that can actually trigger and contribute to leptin resistance too. I'm not going to go too deep into the biochemistry of the mitochondria. It took me back a while when I had to go through this, but they're an incredibly important part of the body, and I'll explain it to you like I do to my patients. They're your batteries. We've got them in almost every cell of the body by your red blood cells. They're highly concentrated in important parts of the body, like your ovaries, your heart, your brain, and they essentially function through electron transfer, and that's their little mitochondria and the electron transfer chain, which is within the wall of the mitochondria. Electron movement through the chain helps the mitochondria generate ATP, our universal currency of energy. So when we're talking about leptin detecting energy, it's ATP is a source of energy. But I'm not going to go too deep, but mitochondria do more than just make ATP. They play an integral role in our intracellular water. They are important at managing our reactive oxygen species. So having healthy mitochondria is fundamental for optimal health. And this is, along with leptin, I do talk a lot about this because I don't think you can actually separate the two. So how do you know if you're leptin resistant without getting a blood test? Common symptoms. So it can be something very non-specific. It can start with just that fatigue, something that just builds over time. I just don't feel as good as I used to, feeling quite tired. I've been to the GP. My blood tests all look normal. Sorry, Mrs. Smith, it's not your thyroid. You hear the same thing again and again. And actually, there's nothing medically wrong, but you don't feel your optimal self. And you could, have gone down some lifestyle endeavors and you can get some improvements, but sometimes it's just not quite lasting. Other things, it can be I've seen people that are very underweight with leptin resistance, and you can be very overweight. Obviously, weight regulation appears to be the biggest issue, and weight loss resistance is a big one. And this is a typical person that unless they really cut their calories, their weight just won't shift, or they've stalled. They've been on a specific diet plan, fasting, whatever, and their weight just seems to hit a bit of a wall, and it isn't budging anymore, despite what they're doing. It's not because they've started to creep bread back in or anything like that. I believe my patients. So that's one of those. Another one is, a typical one is, everyone loves a 16 and 8. I can skip brekkie, easy. I'm not hungry in the morning, actually, and I'm busy, so I'll just get on with it, or I'll have a black coffee if I have to. And actually, one day husband comes along, makes you a beautiful cooked breakfast, and you're like, I can't eat that. So you can actually go as far as feeling quite nauseous at the thought of eating in the morning. But then the opposite can happen further on in the day. So you can find that actually you can have, and this is usually in that second half of the day, it can happen all day, but you might eat a meal, on your plate, you had enough. Normally that would be quite filling and you'd feel good, but it hasn't hit the spot. You're still looking for something else. You just don't feel quite satiated. Some people can never feel satiated and they can overeat. That seems to be the textbook thought of leptin resistance. It's these people that are just sitting there gorging themselves. It's not what I see clinically at all. But there can be a dysfunctional signal of satiety coming as a feedback. And then I've seen some cases where people just say they're never hungry. So they can have a high leptin, and I guess their body's listening to it to some reason. But why is it so high? They just never feel like they have an appetite, and they're always full. So that's the other side of things. And then obviously other things, so a slowed metabolism. So this can be measured. You can get their basal body temperatures, and I do that with some people, but just to kind of get a bit of a metric going forward. Take a basal body temperature, your resting heart rate, and they're quite easy, simple tools that I actually use clinically to say, okay, 6 months ago, this is where your basal temperatures are at. Where are they now, and have we improved? And if that's not getting better, then we're missing something, because your metabolism isn't picking up with what we're doing. So slowed metabolism, and then the downstream effects. And I've put that picture back up there. So leptin, you can have menstrual issues, it can bone, immune system. So there's lots of other downstream effects that can occur with leptin resistance. Testing. So I do check leptin. It's if patients want to, because it costs them money. It's not on Medicare at all. Sullivan Nicolaides in Queensland do it for about $90. I think QML isn't too far off. It's a test taken first thing in the morning. You want to make sure you're fasted for about 12 to 14 hours with water only, because obviously as you eat, leptin will go up. Optimal levels that I like to see for women are about 7 to 10, and for men about 1 to 4. So men do generally sit quite lower. I've actually done quite a bit of testing and thought, I expected that to be way higher, and men seem to get away with the level. But I think that's just where it sits, as there's obviously different reasons for that. So leptin, I have found, clinically tracks quite well with my patients, and I'll present a couple of cases at the end of patients that I've had bring their leptin down. I kind of joke with some of them. I can tell if they've been listening to me by their leptin, because it comes back. And obviously we don't do it often. You need to give it a good 3 to 6 months almost between testing to see a significant change. And I'll have patients that were tracking in the right way, and then all of a sudden it started to go back up again. And when I take a detailed history, they've actually stopped doing some of the things that they were doing that probably was working. So I have seen clinically that it does track quite well. But it's not a test in isolation. You've got to once again look at the bigger picture. I often talk to patients about blood tests being patterns rather than absolute values, because the variation I've seen in leptin numbers are quite profound actually, and it doesn't always track with the amount of body fat that patient might have. So if I've done an in-body scan or a DEXA scan and their body fat percentage, or even just knowing that they're either carrying 50 kilos extra versus 10 kilos extra, I can see higher leptins in people that are carrying less excess body weight than those with more. So it can vary quite a bit. High sensitivity CRP, this is another really good one to tell me about that inflammation. So that's a big one that I do look at. And once again, it can track quite well if there isn't something acute that's come in the way and skewed the results. Reverse T3. Now this is, once again, it's not covered by Medicare either, so it is another out-of-pocket test. And sometimes we'll alternate the reverse T3 and the leptin just to save a bit of money. But reverse T3 is not used widely at all in mainstream medicine. And even in functional medicine, when I learn about it, it still comes down to the thyroid and the conversion of T4. But actually what we're seeing is people with leptin resistance do tend to have a higher reverse T3. And this is something which I do see clinically too. Now, this can be the person where they've got normal thyroid labs, their T4, their T3, their TSH, all looks like it's within range, but they're like, but I'm cold all the time. I've got dry skin, my hair's falling out, I feel fatigued, I've got weight gain, feel just lackluster, lacking motivation, feeling quite flat, ticking quite a few hypothyroid boxes. And reverse T3 is one of those that it acts almost like a block at the receptor site for the thyroid hormone. And that can be something which we see in leptin resistance too. So another mechanism. And then obviously the metabolic markers. So insulin, glucose, urate, liver function, HbA1c, all the stuff that we're all pretty attuned to in this room. Just looking at their actual metabolic health and their background. And it's been very surprising. I think doing what I do and having moved in the direction that I've moved in, I'm not seeing the really high glucose and insulins that much anymore, because generally people that come to me have already really given their diet a good go. They come already having tried to eat pretty well. So generally I'm seeing pretty good insulin and glucosamine but still ridiculously high leptins. So it's been a pretty interesting learning curve coming from the insulin model. And then body fat percentage, so if they have an excess body fat, so that can be once again on a DEXA or an InBody, you can see that. There are some outliers I wanted to mention. So like I said, I believe my patients. So there are some that will be like, no, I actually am doing the things on paper that we've discussed to do, and their leptin just hasn't budged. And the one case that I do see this in, and I guess I haven't been doing this long enough to see if we can get past it yet, is lipedema. And I'm thinking that's more of an inflammatory process going on within the adipocytes that's probably driving that high leptin. So we've found that we're leptin resistant. What can we do about it? I look at this kind of in two broad categories. One is the circadian picture, so trying to actually get our circadian rhythms back intact again, and I go into depth with that in my patients. So in our retina, on our skin, we've got photoreceptors for blue light, which dictate the circadian rhythm within our body. So you signal blue light, you go outside today, your body knows it's not long past solar noon or whatever, it's daytime, and you get that signal back. What are we then doing at night? More blue light. So our circadian rhythms are hugely disrupted. And I work a lot on that with my patients, of how can we navigate our modern life to trick our body into thinking that it is actually the time that it is, because our modern environment doesn't allow for that very well. So there's a few little hacks, and I'll get to practical tips in a minute about what we can do to actually bring that circadian signaling back into the body to help leptin and the brain communicate more effectively. And I think this is one of the biggest needle movers, really. And then the cortisol versus melatonin. So our morning routine dictates a lot, has a big influence on our melatonin later on. So the morning routine is really important, and then the evening routine, and the daytime. It's all important, but there's a method to it. And then back to those mitochondria. Now, what I forgot to mention before was that electron transfer chain. Now, the electrons that transfer through that mitochondria, we thought that, and we're led, I guess, to believe that our energy comes from our food. And it has been hypothesized that only about a third of those electrons that make our energy come from food. You've got the ability to get electrons from your environment. Every time you're barefoot outside, when you're moving and exercising, you're getting infrared from the natural environment or the UV light and getting sunshine. So all these things that ancestrally would have been done without us thinking, and we would have been exposed to all day and all night, we are removed from. And then our energy source does have to come from our food. I often talk to my patients that want to do longer fasts. I say, well, go camping, make sure you get water and electrolytes with you, be outside, be barefoot, be in nature, not in a blue lit office trying to do a 24, 48 hour fast where your only energy source has now just been removed. So actually get in nature and then allow that electron transfer to happen and allow your energy production to happen, and see if fasting is actually easier to do it that way, the way nature intended in the first place. So I talk a lot about infrared, and I don't mean big light panels, you can use them, but I mean just getting outside and maximizing your infrared especially at the beginning and the end of the day when it's at its best. UVA light, which you can only get if you're out at sunrise and sunset, and getting a good amount of UVA, and then actually safe sun exposure with UVB and making sure that you're getting that regularly. Avoiding snacking and actually trying to have a bit of a break between your meals is a big one, and then minimizing your exposure, if you can, to filtered blue light. Nature never made filtered blue light. It's not found anywhere. You get filtered blue light through the glass, you get filtered blue light through our LEDs. We've lost the wide spectrum that we had of that light, and that filtering of the blue light is the nemesis to our mitochondria. It is a problem, and actually trying to minimize that where we can. So special screens on your laptop and glasses that we can use, lighting in our homes, things that we can do, or just get outside, take a break. And I'll talk a little bit about that now in practical tips. Okay, so I really wanted, I could have done the whole talk on this. I really wanted people to leave with, what do I tell my patients to do? How do I get their leptins to come down? How do they get that leptin sensitivity back again? And what is the actual advice I give them? So they've got to start with where they're at. And the tips on here are obviously the ultimate aim, but don't let progress or perfection get in the way of progress, I think is the saying. So just little bits and take your steps towards that. Now, I'm from Queensland, and giving this advice in the winter is a lot easier than giving this advice now. I want everyone to see sunrise, and I tell my patients that if I had it my way, my patients would never miss sunrise, and they'd be outside for it, not through glass. I'll have a lot that say, oh, yeah, it comes in through my window in my bed. No, get outside. I want the natural light getting into your eyes. You don't need to look at the sun. You don't have to see it on the horizon. Bonus, and you're lucky if you do, but just get outside. Get that morning light onto your skin, into your eyes. Bonus, take off your shoes, stop for a minute, breathe, just get outside. If you normally wear contacts, just wear your glasses, and when you get outside, pop them on your head when it's safe. Just try and get your eyes adjusted to that being the beginning of the day. Tell your body the day has begun. Now, if that's a far cry from where you are now, just get outside the second you wake up. Just start with that and work your way from there. I have some patients that are really, really sick, and I say, well, just be wheeled to the window and open the window. Just have the window open and get the morning light in your face. Just start with where you're at. But that's probably one of the biggest tips that I try to start with. So I'm just going to start from the beginning of the day and work up, but people choose when they want to go. And I actually do want to say I haven't focused much on diet in this talk, but I think I'm in the right room where everyone understands it. It's a big piece of the puzzle, and I think you guys have all got the diet down pat, so I don't want to tell you the same thing again and again. But in terms of that morning routine, so I like them to go out, see sunrise, take your shoes off, greet the world, say good morning, and then within about 30 to 60 minutes, and look, some people 30, but once again, meet them where they're at, come back in, make yourself the ultimate aim would be for this to be one of your biggest meals of the day, a really high protein breakfast. So don't skip breakfast. I don't like my patients skipping breakfast. Come in, and then bonus, make that food and take it back out in the sun. Go and sit outside and have your breakfast. Now, like I said, with leptin resistance, a lot of people can't do this. This is one of the hardest steps because they're not hungry. They just don't want to eat. So I say, well, just start with a boiled egg or a small piece of protein, something small, but just trying to get that edible protein in, not a quick shake. I mean, again, if the shake is the best you can do, I'll meet you where you're at. But some kind of food in first thing in the morning. And then as people go along this, one of the signs I say to them that you're gonna actually find is your appetite. You wake up in the morning, and I can attest to this, you're hungry. And that's, I say, you don't need a blood test. I know it's improving just from your symptoms. And that's one of the biggest things I do see. So come in, have your breakfast, ideally first thing in the morning, within an hour of waking. Delay your coffee. Don't have to give it up. Just, if you can, move it to the other side of breakfast. I say it this way, your cortisol naturally rises within that. We've got a 2-hour kind of, you've got a peak and then a almost trough where it kind of levels out a little bit. If your cortisol's already going up, don't give it a nudge. You need to keep some for later. So just, have a nice calm morning. If you move your coffee just out a little bit, about an hour and a half after breakfast, that's fine. You still got your coffee in, but you started your day in a nice calm way with your breakfast, etc., etc. So that's the kind of morning routine. Now, Jack's quite big on the cold exposure in the mornings, and I once again start where you're at. So this winter in Brisbane, I know in Melbourne it's not summer, but it was I would walk with my shorts and singlet on for as long as I could before I felt too cold. So that's cold exposure. Just anything where you're like, okay, I feel a little bit cold. You're telling your body that this is morning. It's a signal. It's a circadian signal. So it can be something as simple as that, depending on where you're at. It could be a quick swim in your own swimming pool if it's a time of year where it's cold. You could go and do an ice bath if you really wanted to. Now, there's nuance to this, and I do say work with a practitioner. I don't want all my patients jumping in an ice bath every single morning. Especially my females with menstrual issues or any kind of stress. There's a fine line, but some form of cold exposure. Some people do a wrist dunk, some people splash their face, some people do a cold shower, which I think is just trauma, but you can do a cold shower if you want to. But something that gets you a little bit cold. That's one of the things I talk about. Try and get as much grounding in as you can in the day. Like I said, it's really good in the morning, but any time of day that you can, take your shoes off. I try and do it. I'll maybe draw the line at the dog park, but otherwise I will try and take my shoes off as much as I can in the mornings. You can get grounding shoes and things to hack, but you can ground on grass, you can ground on concrete, as long as it hasn't got anything painted over it, and try and get that in wherever you can. And then regular sun breaks. So I say to people, people go out for a smoko and it's like on the hour, every 5 minutes on the hour. Just go out and let your body know what time of day it is. So if you are in an office and you need to make a call or anything like that, do it outside. It doesn't have to be in the sun. It can be in the shade. It can be on your deck at home if you're working from home. Open the window. Just get that daylight if you can. In an ideal world on the hour, so your body knows, it's 9 o'clock now, it's 10 o'clock now. Just let your body know what time of day it is. It won't know if you're inside behind a computer screen. So try and bring that in, once again, wherever you can. And maybe you do more on the weekend than you do in the weekday, but just try your best to bring that in a little bit. So doing those regular breaks. Avoid your sunglasses. Obviously, if you're driving and there's glare in your eyes, wear your sunglasses. But what I mean by this is, if you're going outside to do this is the time of day it is signal, and you block the light going into your eyes with sunglasses, you've kind of missed the point. Yes, we do have receptors elsewhere, but the most bang for your buck is your eyes. So put the sunnies on your head and use them as a headband. I don't know. Just get outside and try and avoid that if you can when you're doing your sun breaks, your day breaks. Safe sun exposure. I mean, don't burn, but don't be too scared of it either. So it's a little 5-minute burst to get your vitamin D up and to get your body once again accustomed to what time of day it is. And then I do get people to kind of try and move their, same thing, that cortisol spike. And once again, it's better that you get some exercise in rather than not, but also where are you at? If you're really, really stressed and struggling with your weight and you've got lots on your plate, no, maybe a HIIT workout first thing in the morning isn't ideal. And you might be better with the walk as your exercise for now. So I tend to have that approach to exercise. If we can, try and move it more towards the later end of the day. But you know, while we're healing, maybe taking the foot off the gas pedal a little bit and then bringing it in when your body feels like it's ready to. So that's generally my approach for that. Try to keep 5 hours, I say to my patients, between their meals. So if they've had a really good breakfast and they can't make it, if they can't make it to lunch, they didn't have a good enough breakfast. That's kind of where I go with. And once again, this is a transition. It can take time, but try to have that nice high protein breakfast and then no snacking, and try and just get to that 5 hour mark between the meals if you can. And that could look like 2 meals a day. It could look like 3. It's tricky because dinner is the more social part of the day and is when you see your family. So not many people want to skip dinner. And I don't say they should skip dinner, but if you had a nice 5 hour break, that's enough time to then have a good break overnight. But the key with the meals is, yes, not the snacking in between, but also trying to have your dinner finished at least 3 to 4 hours before you go to bed. And in an ideal world, which will get easier in the summer, try and have dinner done before the sun's gone down. Bonus, watch the sun go down once you finish dinner. And I do want you to watch the sun go down, because that's another one. Oh, sun's going down. So you're letting your body know what time of day it is again. But trying to have that little gap, that good gap between finishing dinner and going to bed, once again allows that leptin signaling to happen overnight, allows the insulin spike to have come down, and allows that better communication. So that's the other thing that I work on. Regular wild seafood, DHA and iodine. So that's one thing I will say, whatever diet you're on, is trying to bring in some more wild seafood. I generally say if you're in a blue lit office all day, that's a day to really try and get more in, to try to mitigate some of that mitochondrial issues that are happening with the blue light. And then blocking your blue light at night. I think this is probably the hardest piece of the puzzle, and the only bit that, unless you're going to sit in candlelight, probably isn't completely free, because you might need some tools to help mitigate the modern environment in the evening. Our indoor lighting isn't great. There's LEDs, that bright, that narrowband blue light at night is not sending the right signal to your brain about what time of day it is. You watch the sun go down, you need to tell your body the sun's gone down. A low salt lamp or lots of low lighting is one thing. You can put candles on. If you're wanting to look at screens, there's Iris software that I have on my laptop, and it goes red. My phone screen goes red. So there's lots of little things that you can do. I chuck on some red glasses, and Block Blue Light are pretty good, or Bon Charge. They're two of the companies that supply good blue blocking glasses at night. And these I've found, and when I was telling you, I can tell when their leptin's off. Often I'll be like, oh yeah, those red glasses, I haven't been wearing them. And then I'm like, oh, I'm not saying it's that alone, but little things, that circadian rhythm disruption, and I can see the leptin can start to come back up again. So trying your best to do the best you can, and especially in that hour or so before bed. So if you are watching a bit of TV and you've got the blue blockers on, it's not the end of the world. I'm not going to lie, I might sometimes have a pillow and a blanket, but at least the blue blockers to kind of hide the blue light. So trying to block that, and then obviously allowing yourself a good amount of time in bed so you can make it up for the sunrise. Now, I'm just going to just quickly run through a couple of cases just to conclude. It's hard to choose what I wanted to actually put here today. I've gone with two that kind of represent a lot of the type of patients that I see now. I've been working on leptin probably for nearly 2 years. So I've got a few where I've seen successive changes. And I'm just going to talk a little bit about Mrs. A. Mrs. A, she's a 52-year-old. So when she came to me, she'd had a history of chronic yo-yo dieting, loved a good Weight Watchers, had done keto for ages, 5 and 2, lots of fasting, and was always able to actually get her weight to respond and come back down. But she came to me saying, well, it's not working. I've gained 14 kilos. I've now got migraines. I'm really tired. And I'm not actually quite getting the results that I used to get. So we did some initial blood work. This was October 23, and found, and I was quite surprised that her leptin was 80, which, like I said, 7 to 10 is where you want to be. But she was insulin sensitive. Her insulin was 4 and her glucose was 4.8. And she felt she was carrying 14 kilos extra. I mean, you look at her, she did not look obese or overweight. I appreciate that she wasn't comfortable, but she wasn't by any means grossly overweight. So We worked, I just said we're going to just do a simple paleo reset. Those practical tips I showed you before, I pretty much gave her those, made sure she was reaching her protein target at her meals. We started to work on it. She herself went and did a bit of cold exposure and brought a red light panel and wanted to do a bit more. And about, when was the next one? I think in April, her leptin had halved. Which was great, and I'm really glad it had, because she was quite frustrated that the weight hadn't shifted yet. And she's like, oh, I give up on this, it's not working. And then we looked at the blood work and she's like, oh, wow, okay. But what she hadn't realized is that she should reduce her migraine medications, and other things had started to improve. So she hadn't quite lost all that weight, but she persevered because she was quite impressed with a reduction from 80 to 42. And then we continued on, and once again, weight started to actually shift a little bit. So bear in mind, she's eating a lot more calories now than she was when she met me. So we had put her onto a more nutrient-dense, higher calorie type diet. And her leptin, most recently we checked, was 22. Her weight has started to shift. Yes, she wants it to be quicker, but it has started to shift, but she's still got a leptin of 22, and our target is 7 to 10. So it's all about education, I guess. She's feeling a lot better in herself. So what I wanted to show is that time frame between the leptins is pretty big. And this is kind of why I check it, so we can actually show that there is progress going on here. You are healing, things are improving. But if we focus just on the weight, we're gonna miss the bigger picture here, and then what else is going to happen from the inflammation or whatever that might be going on in the body. So it is a slow game, but it does seem to work. So case 2 is one of my long-standing patients. She was in her 30s. She was just not feeling very good, fatigued, menstrual irregularity, joint pains, just feeling quite lethargic, and had already been actually on a quite long-term low-carb diet. Very similar story. Had success initially, and was finding that actually, be it stress, be it life, just wasn't feeling as good. We checked her blood work. Her leptin was in the 40s. She actually, because she'd been a long-term patient of mine when she was on low carb, her initial, when she first started low carb, I think she actually went to carnivore at one point, her insulin and her glucose were really good. They were quite low. She actually got an insulin, I think it was about 2, and a glucose in the 4s. But when I saw her, and once again, not because she'd let the diet go, she was still low carb, her insulin was starting to creep up a tiny bit, her blood glucose was creeping back up a little bit, and her leptin was in the 40s. So we started the leptin reset, focused heavily on the circadian stuff, kept the diet largely where she was. She probably had a bit more seasonal variations with maybe fruits and veggies that were in season at the time in her area. And then for some months later, checked leptin. It was 22. She was feeling a lot better. Weight hadn't shifted. And this is the same thing I want to show in those cases where the leptin's plummeted down. And I see this again and again. The leptin can come right down, but the weight hasn't moved yet. So that from mid-40s to mid-20s, there was no change on the scales as such in her weight. And then the perseverance, she actually said to me before we checked it, I know it's down. She goes, I'm hungry in the mornings. I feel really good. I'm losing weight. She'd lost 10 kilos. And we checked her leptin and it was 8. And this was a few weeks ago. So it is a slow process. But she feels good. She's not had to restrict her calories. She's still on a generally lowish carb diet, and just is following a lot more than just the diet principles now. She follows a lot of the stuff that I've talked about in the practical tips. So I guess I want the practical tips to be something that you take home. For anyone wanting to look a little bit deeper into this, Max, I highly recommend looking into some of Max's work. He's got a couple of really good courses online. One is the Circadian Reset course, which actually pretty much goes through similar to what the leptin reset is, and helps coach patients through it. His Solar Callus, once again, getting safe sun exposure, helping those mitochondria. He's got some amazing podcasts. He's actually done 3 podcasts with Jack Kruse that I'd recommend listening to, just to understand the foundation for all the leptin work. And then there's a couple of ladies from America, Carrie and Sarah, who have got some good quantum conversations, some good podcasts. So look, I wanted to plant the seed today, but there's a lot more depth to understanding leptin. And if you really want to know go deep into the science or whatever, there's some great information here. And I highly recommend looking into it. So thank you for your time today.